Welcome back to the second part of our colorectal virtual education series bonus episode. Again, I'm Lauren Weaver, a general surgery resident and one of the colorectal virtual series education fellows.
And I'm Connie Gann. I'm a general surgery resident and the other colorectal virtual series education fellow.
The last episode, we talked about benign diseases, and today we will be presenting high-yield ABSITE content on malignant colorectal anal pathology. Again, this content is based on the SCORE modules pertaining to these topics. Just like part one, this episode is designed for active learning. So if you haven't already, go ahead and print off the review PDF attached to the video, grab your colored pens, pencils, or markers, and follow along with us. Once you listen to this episode and complete your review PDF, you can use it for future reference. For the most efficient ABSITE studying, we highly recommend you print off a blank PDF, try to fill it out from memory, then check your work with the review PDF you completed during this episode. That way, you can identify content you don't know and focus on studying your weaknesses rather than the areas you're already an expert in.
Okay, so let's dive in. We are going to start with colorectal cancer screening guidelines. Lauren, can you start off by telling us when screening starts for the average risk patient, as well as the different screening modalities?
Sure. So for the average risk person, the recommended starting age of screening is 45 years old up till the patient is 75 years old. Past 75, from the ages of 76 to 85 years old, the screening guidelines are individualized. As far as screening modalities, there are several. One is colonoscopy, and an average risk person will be tested every 10 years. Another option, which is a newer one, is CT colonography, and that will be a test every 5 years. And another option is a flex sigmoidoscopy. That will be every 5 years as well. And then patients can also get a fecal occult blood test or a FIT test, and that testing interval is annually.
And what about patients who are high risk or have elevated risk?
These patients are patients who have gotten a colonoscopy and their pathology findings designate them into those elevated or high risk categories. So if we go to the table below the screening guidelines, we can go into that in further detail. For elevated risk findings, so these patients, when they got their colonoscopy, they either were diagnosed with a tubular adenoma with low-grade dysplasia or a serrated polyp without dysplasia. Now, to have these different pathologies and be in the elevated risk category, they would have to have less than 2 polyps, and those polyps would have to be less than 1 centimeter. If they are not, then the patient may be in the high-risk category. In the high-risk category are patients that had pathology that showed a villus or tubovillus adenoma. Their adenoma could have shown high-grade dysplasia, or they could have had a serrated polyp with dysplasia. They are also high risk if they have a polyp over 1 centimeter or if they have 3 to 10 polyps. If you are considered elevated risk, we can go back to the cancer screening guidelines. If you are elevated risk, the recommendation is for you to get a colonoscopy in 5 years. And then if that is negative, your follow-up would be a repeat colonoscopy in 10 years. Then for the high-risk category, it would be recommended that patients undergo a colonoscopy at 3 years. And then if that's negative, they can span out the colonoscopy to every 5 years.
What about patients who have a first-degree relative who has a history of colorectal cancer?
If your first-degree relative is under 60 years old, or if you have 2 first-degree relatives at any age, The recommended screening age is either 40 years old or 10 years before the earliest diagnosis, and you pick at whichever screening age is earlier. And the screening modality that's recommended, and I would pick on ABSITE, is colonoscopy, and your testing interval would be every 5 years. If the first degree relative was over 60 years old, or you had two second degree relatives diagnosed with colon cancer, then you would start screening at 40 years old. And the modality would be colonoscopy, and that interval would be every 10 years. So the interval would be the same as an average risk person every 10 years.
You would just start earlier.
Correct. You would just start at 40 instead of 45.
And what about patients who have been diagnosed with inflammatory bowel disease?
So for these patients, you want to start screening 8 years after they are diagnosed with either their Crohn's or ulcerative colitis. And the screening modality is, again, colonoscopy. They would get screened at an interval of every 2 to 3 years.
Okay, for the last section of colon cancer screening, this will be for patients who've been diagnosed with a genetic mutation. So those who have either Lynch syndrome or familial adenomatous polyposis.
So let's start with Lynch syndrome. So patients diagnosed with Lynch syndrome, it's recommended that they undergo screening starting at 20 to 25 years old, or 10 years before the earliest colon cancer diagnosis in their family. And the screening modality is colonoscopy, and that interval will be every 1 to 2 years. For FAP, the screening will start at 10 to 12 years of age. The modality will be a flexible sigmoidoscopy, and the screening interval will be annually.
So next we'll be talking about colorectal cancer staging.
Connie, for colon cancer staging, how do we figure out what the T stage is?
Yeah, so the T stage is dependent on the depth of invasion of the tumor. So as the T stage increases, the more invasive the tumor is into the colon or rectal wall. So a T1 tumor invades through the submucosa. A T2 tumor invades through the muscularis propria. T3 tumor invades through the muscularis propria into the subserosa, and a T4 tumor is invaded through the entire colon wall and might be on the adjacent organs.
Great. What about for staging? How do you remember or think about the staging for colon cancer?
I think about the staging from both ends. So first, I think about stages 1 through 4. So stage 4 is any colon cancer that has any metastases. So if there's any M1A or M1B, and usually these are lung or liver metastases. Then I think about stage 3. So stage 3 is if there's any nodal involvement, but no metastases. So it can be N1 or N2. N1 means 1 to 3 nodes, while N2 means 4 or more. Then to distinguish between stage 1 and 2 is just the depth of invasion, or the T stage. Stage 1 includes T1 and T2, but no nodal or metastases. And then stage 2 includes T3, 4A, and 4B. And so T3 is it invades past the muscularis into the serosa.
Right. And stage 1 colon cancer only invades up to the muscularis propria. So just to recap, stage 1 invades up to the muscularis propria. Stage 2 invades past the muscularis propria into the subserosa or past the colon wall. Stage 3, any nodes. Stage 4 is any metastases. All right, great. Next, we're gonna move on to talking about T1 adenocarcinomas. After colonoscopy, you take out a polyp and the pathology comes back as a T1 adenocarcinoma. The ABSITE is going to ask you, what are you going to do next? Are you done? Do you need an oncologic resection? What do you do?
The pathology of that tissue is really important. So you'll need to check for the grade, invasion, and margins. We have icons in your PDF sheets to help remind you of these three things. A+ on a paper is to remind you of a grade. An alien spaceship is to make you think of an invasion. And margins sounds like margarine, so we put in a stick of butter there. But getting back to the specifics on the criteria, the T1 polyp must be well or moderately differentiated. No lymphovascular or perineural invasion. No deep submucosal invasion. And a tumor margin of 1 to 2 millimeters. If the polyp meets all of these criteria, then no further resection is needed. Otherwise, the patient will need an oncologic resection with a partial colectomy, depending on the location of the polyp.
What is the workup for a patient with a newly diagnosed colon cancer?
One of the first things that you need to think about is whether there is additional cancer. One of the imaging things that you could do is a CT chest, abdomen, pelvis. And here we have an icon with the cap to kind of describe the chest, abdomen, pelvis, and then icon saying no PET scans as like a pet animal. And then the second portion would be to do a completion colonoscopy to make sure there's no additional polyps or cancer in other areas of the colon. And the telescope is to represent the colonoscopy. In addition, you want to do a CEA marker as a blood test to see if this cancer follows this tumor marker. And CEA, if you spell it out, sounds like C. So that is the icon there is with the wave.
Who would you recommend gets neoadjuvant chemotherapy for a colon cancer?
Patients should get neoadjuvant chemotherapy for colon cancer if they have T4A or B disease. This is mostly if their tumor is borderline resectable or unresectable with no metastases.
Right. So I think bottom line is if you can resect the cancer, go ahead and resect. For patients who are undergoing a resection for colon cancer, what is the surgery that they get?
So they would undergo a colectomy that follows the blood supply.
Okay, and then what margins would you take?
You're looking for 5 centimeter margins.
How many lymph nodes should you get in your oncologic resection?
You would want at least 12 lymph nodes. That would be the minimum.
Who gets adjuvant therapy for colon cancer?
Any patient that has colon cancer past the muscularis propria ends up needing adjuvant chemotherapy. So stage 2 and 3, and then stage 4, that's your mainstay of therapy.
All right, Connie, what is the adjuvant therapy that patients would get if they have colon cancer?
These are most well known by their abbreviations, so FOLFOX or CAPOX. But FOLFOX broken down, it stands for folinic acid, 5-FU, and oxaliplatin. And then CAPOX stands for capecitabine and oxaliplatin.
This is another question that the ABSITE likes to ask. What is the surveillance for colon cancer?
After a patient has had surgery, they get surveillance with 3 different things. They have an office visit and a CEA tumor marker completed every 3 to 6 months for 2 years. And then after that, then they have an office visit and CEA test every 6 to 12 months for 5 years. In addition, they have CT chest, abdomen, pelvis imaging to see if they develop any metastases, and this is done annually for 5 years. Third aspect of colorectal cancer surveillance, this is the colonoscopy. So if you're able to get a pre-op colonoscopy, then you don't need one until 1 year after surgery. But if you were not able to get that pre-op colonoscopy, then you would need one about 3 to 6 months after surgery. After this first colonoscopy after surgery, then you don't need another one for 3 years.
Our next topic will be rectal cancer.
So Lauren, how is a diagnostic workup for rectal cancer different from colon cancer?
Yes, great question. ABSITE loves to trick you on this. Patients with rectal cancer, for their staging and workup, you want to get them an MRI. Specifically, you're interested in the T2 weighted MRI. Another option that will help stage your rectal cancer is endoscopic ultrasound. Ultrasound is better for early stage rectal cancers. However, you can't see the entire lymph node basin. So that's why I would pick MRI on an ABSITE question. Every patient with a rectal cancer should have an MRI, not necessarily an endoscopic ultrasound. We have an MRI icon, and then we have an ultrasound icon with a sunrise to remind you that endoscopic ultrasound is better for early staged rectal cancers. However, I just want to emphasize that I would pick MRI on the ABSITE, but I highly doubt they put MRI and endoscopic ultrasound together as an answer choice.
Got it. And what are the surgical options for rectal cancer and who qualifies?
Yes, so there are many surgical options for rectal cancer. We'll start with the least invasive. That would be local excision. Local excision includes a transanal resection or TAMIS. A local excision is reserved for rectal cancer that is considered a low risk T1 cancer. Another more invasive option is a low anterior resection. That's indicated based on your cancer margins and how advanced the tumor is, that you can spare the sphincters and still get good tumor margins for your oncologic resection. Another more invasive surgery is an abdominal perineal resection, or APR. This is for patients in which the rectal cancer involves the anal sphincters, or it's not possible to get a distal margin that's adequate for an oncologic resection. Lastly is a pelvic exenteration. Patients can get this if their rectal cancer invades other pelvic organs and they also have no unresectable metastases.
Yeah, I feel like the pelvic exenerations are often done in conjunction with OBGYN and urology, depending on where the tumor invades.
Yes, those are often combo cases.
What is the criteria of a low risk T1 rectal cancer?
To be considered a low risk T1 rectal cancer, the rectal cancer has to be less than 3 centimeters in size, less than 30% the circumference of the rectal wall, you have to have over 3 millimeters of clear margins on the initial resection, usually an endomucosal resection or polypectomy. The T1 cancer has to have a favorable histology. So no lymphovascular invasion, no perineural invasion, and the lesion has to be well or moderately differentiated. So it's similar to the T1 colon polyp low risk criteria, but a little different.
Got it. And what is the most common complication from local excision?
That would be urinary retention.
Okay. And who gets neoadjuvant chemoradiation in rectal cancer?
Those are patients diagnosed with a stage 2 or greater rectal cancer.
And what are the outcomes of neoadjuvant chemoradiation?
So neoadjuvant chemoradiation reduces the risk of local recurrence and improves disease-free survival.
Now let's talk about treatment after surgeries. Who gets adjuvant therapy?
These are patients who did not get total neoadjuvant therapy prior to surgery, and they are diagnosed with a stage 2 or greater rectal cancer.
Got it. And what are the outcomes of adjuvant therapy?
Adjuvant therapy has been shown to improve survival and reduces the occurrence of distant metastases.
Now, one of the hot topics of rectal cancer treatment right now is who can undergo watch and wait.
These are patients who had a complete response to neoadjuvant chemoradiation or total neoadjuvant therapy, also known as TNT. And these patients undergo a very rigorous follow up to see if they have a recurrence, but you just watch them and wait instead of rushing them to surgery to get an oncologic resection.
Next, we'll talk about operative caveats. So the first question is, does a diverting loop ileostomy prevent leaks?
This is a common question I get in the operating room, but a diverting loop ileostomy does not prevent a leak, but it does decrease the risk of patients developing pelvic sepsis or peritonitis if they do get a leak.
Got it. Where do you stop dissection during a prostatectomy?
You're going to stop when you see the levator ani. That's when you know you've gone low enough.
Okay. What is the advantage of a total mesorectal excision, or otherwise called TME?
So patients who get a TME, it's been shown that those patients have a lower rate of local recurrence. And it also gives the oncology team a better staging information for that patient.
So for patients who are on bevacizumab, do they need to delay surgery?
Yes, it's recommended that these patients wait 6 to 8 weeks before undergoing a surgery.
Lauren, will you commonly give your patients with rectal cancer bowel prep before surgery?
Yes, bowel prep that includes a mechanical prep. So drinking the Go Lightly, doing the enemas, clearing out their colon, and then also giving the patient oral antibiotics to take and giving them their normal pre-op antibiotics. All three of those together have been shown to decrease surgical site infections.
Bowel prep as well as antibiotics in combination are important to decrease infections. So something that can be kind of tricky in the operating room, what are ways to ensure proper length for a left-sided anastomosis?
Yes, this is a great question for the ABSITE and to know from a practical standpoint when you're operating with any colorectal surgeon. But to get proper length for your left sided anastomosis, you can do high ligation of the inferior mesenteric artery. You can divide the inferior mesenteric vein at the inferior border of the pancreas. And then lastly, you can mobilize the splenic flexure.
And next, we're going to be talking about anal squamous cell cancer.
Connie, what is the most common HPV subtype that causes anal squamous cell cancer?
And that'd be HPV 16.
What patients are at high risk for getting an anal squamous cell cancer?
So these are patients that have a history of sexually transmitted diseases, partake in anal receptive sex, smoke, or are immunosuppressed. So that includes patients that have a history of HIV, have a history of a transplant, or are on chronic steroids.
Connie, is a low grade squamous intraepithelial lesion or lysol considered premalignant?
Lysol is not premalignant, but can progress to HISL or high grade squamous intraepithelial lesion, which is premalignant.
Okay, so next we're going to go through all the different anal lesions you can have and their respective treatments. Connie, patient is diagnosed with a lysol. What do you do for that patient?
A lysol is otherwise also known as AIN1. And for this patient, you observe their lesions.
Okay, what about a HISL? What do you do for that patient?
Yeah, so HISL, as mentioned in the previous question, is now premalignant. And this is also considered AIN 2 and 3. So you would have to undergo ablation.
All right, now your patient is diagnosed with a squamous cell carcinoma of the anal canal. What do you offer them?
Yeah, so they should undergo the NIGRO protocol.
So, not surgery.
No surgery.
Okay. And what if the patient has a squamous cell carcinoma of the anal margin, also known as the perianal skin? What do you do for those patients?
Yeah, so it depends on whether the lesion is well differentiated and the size. So if it is well differentiated in less than 2 centimeters, then they undergo wide local excision with 1 centimeter margins. If it's an advanced squamous cell of the anal margin, so it's anything that's not well differentiated and more than 2 centimeters, usually you undergo chemoradiation therapy.
All right. And then what about if a patient has an anal melanoma? What do you offer them?
Then you would refer to the melanoma guidelines.
Great. So you would treat it like any other melanoma. Now the patient is diagnosed with an anal adenocarcinoma. What do you recommend for this patient?
Usually you undergo chemoradiation therapy, but depending on the patient, you could also do abdominal perineal resection.
You mentioned the NIGRO protocol before, and what is the NIGRO protocol?
Yeah, so there's 3 components. The first one is mitomycin C. The second is 5-FU. And the third is radiation. This radiation includes 50 grays to the primary site, as well as 35 to 45 grays to the pelvic inguinal lymph nodes.
All right. Thanks for explaining that, because I feel like this is a question every year on the ABSITE when they ask you about a squamous cell cancer of the anal canal, and they always try to get you to pick surgery, and the patient should not get surgery. They should get the NIGRO protocol. Okay. And then what is the workup for a newly diagnosed anal squamous cell carcinoma?
I guess the first thing is to do a physical exam with a digital rectal exam, inguinal lymph node palpation, and this can be with or without a fine needle aspiration. The second aspect would be to look more closely at the lesion with endoscopy, with or without biopsy. And then the next part would be imaging. So you could do a pelvic MRI, a CT chest, abdomen, pelvis, and then with or without a PET scan. You would want to do a PET scan if the lesion was more than 2 centimeters. And then if the HIV status is unknown, then you want to do a HIV blood test.
What is the follow-up for patients after completing the NIGRO protocol?
So after they've completed the chemotherapy and radiation associated with the NIGRO protocol, then they would undergo a digital rectal exam, endoscopy, and inguinal lymph node palpation every 8 to 12 weeks.
Okay, and what if the patient has finished their NIGRO protocol, their chemo radiation is done? What if there is persistent disease on follow-up? What do you do?
Yeah, so if there's persistent disease and it's been less than 6 months since they completed the protocol, then they would continue to watch and reassess the disease. But if it's been more than 6 months and there's still persistent disease, then at that time you would restage and rebiopsy the lesion. And depending on the results of that, then you may perform a salvage abdominal perineal resection.
All right. And then what surveillance is needed after an anal squamous cell carcinoma remission?
After your disease has gone into remission, you would undergo a digital rectal exam, anoscopy, inguinal lymph node palpation every 3 to 6 months for 5 years. And then in addition, you would need a CT chest, abdomen, pelvis annually for 3 years.
Okay, now we're going to switch gears. What if a patient complains of a pruritic, erythematous, eczematous anal lesion? What do you think that could be?
The fact that it's very pruritic and kind of has eczema associated with it, I'd be thinking about extramammary Paget disease.
And what is that type of lesion associated with?
It's associated with a concurrent GI malignancy or a tubo-ovarian malignancy.
Great. And then which of those two is the most common?
The most common is a concurrent GI malignancy.
And then what additional workup is needed for this type of lesion?
You would need to biopsy the lesion as well as rule out a concurrent malignancy with a CT abdomen pelvis or colonoscopy for that most commonly concurrent GI malignancy.
All right. And how do you treat this lesion?
You would excise it with wide local margins and you would want negative margins.
Okay. Next topic we're going to go to is appendiceal cancer.
Okay, so Lauren, after an appendectomy, the pathology shows a 0.8 centimeter carcinoid tumor with negative margins. What do you recommend at this time?
I would recommend no further treatment for that patient. Since the carcinoid tumor is less than 1 centimeter, you don't need any further resection.
You don't need any resection in this situation, but when would you recommend a right colectomy for appendiceal carcinoid tumor?
I would recommend a right colectomy for a patient who has a carcinoid tumor that's over 2 centimeters. If the patient has a carcinoid tumor in the 1 to 2 centimeter range and they have mesoappendiceal invasion, if they have positive margins, if it's high grade, if there is angioinvasion, or if it's mixed histology with a more aggressive pathology like goblet cell or adenocarcinoid, then I would recommend a right hemicolectomy for that patient.
Yeah, so it sounds like if it's smaller than 1 centimeters, you could just observe. If it's more than 2 centimeters, you resect. But if it's in the middle, it kind of depends on the risk factors of the tumor.
Right. If it had any risk factor that went into that it was more aggressive, you would just do a right hemicolectomy.
And what if the appendix pathology comes back as adenocarcinoma?
If you have an appendiceal adenocarcinoma, then you would go ahead and proceed with a right colectomy.
Okay, and then what is the best treatment for peritoneal mucinous carcinoma or PMCA?
This is a little bit debated, but it's cytoreductive surgery with or without HIPEC. And the cytoreductive surgery is the key point, but that has been shown to improve progression-free and overall survival for these patients. That wraps up our malignant review.
Now you can use your completed review PDF for future studying. We also included a blank review PDF if you really want to test yourself. Happy ABSITE studying! If you like this episode or have some feedback for us, please leave a comment or fill out our survey. Otherwise, see you for our weekly episodes, Sundays at 7 p.m. Eastern Time.